So we're excited to be here today, and as you know, we all have the same common interest tonight, and that's atrial fibrillation. So we're delighted you could spend the time, and we're honored to have you here. So as we said, we're going to go back and forth. It's going to be a tag team kind of thing. So we'll talk about a little topic and pass it back and forth, the baton. So this is my team in cardiac arrhythmia. So there's a whole team. It takes a village. So here we are. We're going to talk about atrial fibrillation. What is atrial fibrillation? What should we be thinking about? So first of all, people ask, well, would I feel atrial fibrillation? And the answer is sometimes some people feel atrial fibrillation, others don't. But what are some of the symptoms we would talk about in atrial fibrillation? So there are a variety. It can be from what we call palpitations, which could be a racing heart, jumping around kind of feeling. It could be something a bit more severe, dizziness or loss of consciousness, not as common. Something like shortness of breath or chest discomfort, they also could be symptoms of atrial fibrillation. And finally, something more general, fatigue, lack of energy, exertional intolerance. Many of us might feel fatigue from time to time. So we wouldn't know necessarily what's the cause, could it be atrial fibrillation? So these are the variety, the range of different things to think about. So as we kind of think, we'll talk more about kind of things that relate to atrial fibrillation, but we wanted to put up here things that we say precipitate. We'll often use the word trigger. So we don't say that these cause atrial fibrillation, but very often something that happens might have atrial fibrillation happen at that one time. You may ask yourself, well, why did atrial fibrillation occur that day? Well, maybe I was a little bit more exhausted, fatigued, dehydrated, those kind of things. Other miscellaneous things you see here include caffeine, alcohol, other kind of things that might upset the overall systemic condition, sleep disorders, stress. We often are asked, well, gee, I had a procedure, I had a colonoscopy, I had a surgery, and during that procedure, they actually either I had atrial fibrillation or they may even diagnose atrial fibrillation then, because those things might trigger it, because they're important things in our lives that happen. Other general things that we may come back and talk about are things like overactive thyroid, and even exercise sometimes, or going to elevation. Those type things can, put a different kind of stress the body under those kind of circumstances. So you can get the flavor. There's a big range of things, but these are really common. We hear about these all the time, over and over again. But let's turn into what is atrial fibrillation. And so there are many ways to think about it. We have a little diagram, little arrows going around, and things are just kind of moving rapidly. The electrical signals of the heart are moving rapidly through the upper chambers. And it's not a one specific pattern. It's really just a kind of a swirling around. The next thing that people ask, well, gee, I've heard a lot of people have AFib. There must be a lot of people, and indeed there are. There are many millions of people in the United States that have atrial fibrillation associated with increased risk of stroke. And this I like a lot. This graph shows in the dotted line, it shows the US population. And then in the green bars, you see atrial fibrillation, the distribution of age. And so this is a condition largely of people between 60 and 85. The bulk of the people who have atrial fibrillation, as you see here, there are people with different, beyond in either side, but that's where the bulk of the patients are. So, and as you can see, what's happening to our population as we age, the baby boomer group there gets older and older. You can see why we're going to have more and more atrial fibrillation, more than we even have today. So that's just to kind of get a picture. You're not alone. Many people have it. So that's why we kind of talk about it in this kind of setting frequently. You'll hear about atrial fibrillation that kind of comes and goes, things like that, and that's what we call paroxysmal AFib, or sometimes it kind of gets stuck in atrial fibrillation. We call that persistent AFib, and you might need electrical shock or some other treatment to cause it to go back to normal. So I'll kind of, I'll talk a little bit about, we mentioned a little bit about this, but the graph I showed kind of indicates there is an influence of age. Just with every decade of life, our likelihood of having AFib is going to get greater. And so we do know that. There is a factor, particularly we see this with our younger patients. We do have patients in there, believe it or not, in 20s and 30s who get atrial fibrillation. They are more likely to have a genetic predisposition that very often we can identify. And then you'll see listed here a number of very, very common conditions, high blood pressure, diabetes, sleep apnea, overactive thyroid, other forms of heart condition, whether it be a heart attack or something we call cardiomyopathy, might be things that could be contributing in addition to age and these other factors we've talked about. So that's kind of where we would start in thinking about atrial fibrillation. I'll turn this over to Dr. Lin in terms of any comments he wants to make about kind of how we identify atrial fibrillation. In the primary care setting, what are the circumstances he sees atrial fibrillation most commonly? So,
I think, it's a great question, and thank you for the excellent background. A couple of things. I frequently am the one who diagnoses atrial fibrillation because a lot of times people don't see a cardiologist for any other reason. And we frequently diagnose this based on an EKG, so an electrical test of the heart that many of you may have had, or a longer term test where it's a heart monitor where you wear, there are different types of those heart monitors for a prolonged period. And then we look at the heart monitor and see whether the person went into atrial fibrillation or not. Some people, we pick it up incidentally, but a lot of times, just anecdotally based on my own experience, it is associated with alcohol use. We teach medical students, Saturday night heart used to be the saying, caffeine, stress, post-operatively, so that's a very common situation, but can also come with no trigger. So frequently patients will ask me, why did I have this? And, sometimes we don't really have any known antecedent cause. So I would say, a lot of times also people are seen after discharge from the hospital. So now in the United States, we keep people for a very short time, and usually they're on a general medical service. They don't typically see a cardiologist at that point. They get discharged and they say, okay, you were diagnosed with atrial fibrillation. Sometimes they're started on a treatment. Sometimes they say, hey, you're better, see your primary care doctor. So I frequently see people after they're in the emergency room or the hospital, and then I have to work with the patient to decide what they want to do, and frequently that involves referring to cardiology.
Yeah, great. So terrific. So let's go to our
questions, or
I think we'll go to the end,
okay.
and then we can come back.
Sure.
I think it will be plenty of time. So the next question is really how then can we think about controlling atrial fibrillation? And so then we'll talk a little bit about that. So one of the things, as we've kind of talked about, you have this visual, the little arrows moving around in the upper chamber, the atria. They're doing this really fast. They're kind of spinning around at many hundreds of beats per minute. But they go through a little connector we call the AV node that connects the top floor and the bottom floor of the heart. And it's the number of beats that get to the bottom chamber that determine our pulse, how fast it's going. So that's what very frequently the patient will say, it's jumping out of my chest, it's going really fast. That's how many get from the top to the bottom. So you can probably think just right now yourselves, well, what would be a way that we could make our patients kind of immediately feel more comfortable? Okay, and so that's shown here. We can affect that connector, the AV node that connects the top and the bottom floor. I say it's like turning the faucet down, so less kind of water comes through, right? And so that's going to really calm down the heart rate. You're getting the heart to not go as fast as otherwise. And so doing so, we find that patients often can go from pretty symptomatic, jumping around, to minimally symptomatic, barely even know they have it. And so that's one of the big determinants of symptoms is how fast it's jumping around. If you can calm it down, that's often a very simple, usually really safe thing to do to be able to make the patient feel pretty quickly better. And so that's one of the very first principles that we use to control atrial fibrillation. If we go on, however, and say, okay, well, we've done pretty well in controlling the rate, but the patient has still symptoms, things like we talked about, like shortness of breath and just not enough energy. And then we kind of turn to what we call rhythm control, and that is getting the rhythm back to normal. So the first thing we talked about in the last slide was just controlling the rate. That doesn't mean changing the rhythm back. It just means in atrial fibrillation, it's not as fast jumping around. But now we're trying to achieve a different goal. That is to get the person to go from atrial fibrillation back to normal. And we can use certain medicines, ones that I've listed here. These are 6 different medicines called antiarrhythmic agents, so kind of getting the rhythm back to normal. And we use these in order to accomplish that, get them back to normal rhythm so it's nice and, back to normal, peaceful kind of rhythm. If that doesn't work, we actually sometimes will suggest a procedure. These are plastic tubes called catheters that we insert in the body, and then we kill little islands of cells that are responsible, and that's something called ablation. So that's for people who remain symptomatic despite these different steps of rate control, rhythm control, and that would be many of the different things that we might look at. So I'll turn things over to Dr. Lin and say, well, in terms of, from a primary care point of view, what do you think about kind of the different early steps in controlling AFib? What do you find most useful? How do you work with your patients in thinking about that?
Absolutely. I think that was a very clear explanation. I want to emphasize something that Dr. Wang just said, and one thing that I think is frequently misunderstood, not just by patients but also by primary care doctors, is the difference between an antiarrhythmic and a medicine to control symptoms and heart rate. Frequently, I'll have patients tell me that, oh, I'm on a drug called metoprolol, and that's why I'm not in atrial fibrillation. So one takeaway point I want to really emphasize is that what Dr. Wang said is that these are not antiarrhythmics. These are really to control heart rate and therefore reduce symptoms. The second thing I would say is that there is a lot of uncertainty among patients about catheter ablations, and anxiety associated with that. So, I really encourage people, and maybe you could speak just for a minute about how efficacious do people need 2 ablations. So I think there is a lot of confusion. Some places you'll go, and sometimes you'll hear, wow, this will be the best thing since sliced bread, or at least that's what the patient hears. I don't know what they're told, but I would love, I think that's a big area of confusion for my patients.
Sure, that's great. Yeah, that's really important. And it really speaks to the need to individualize. As you can imagine, each patient comes with a different set of goals and a different perspective, what they value. We always talk about that, like, what are the values of the patient? What are things are more important? And that's in terms of procedural risk, what they think about taking medicines, all those kind of things. Sometimes we, of course, get told, well, I don't want to have a procedure and I don't want to take medicines and I want you to fix me. Well, that can be difficult. But, so there are certain limitations, but there is often a balance. And so I think every doctor, primary care doctor, specialist, will work with the patient and try to find out, well, for the next step at least, we don't have to work too many steps ahead, but for the next step, what makes sense for you? What do you value? Do you want the least, invasive kind of approach? Let's do this first, or do you want to kind of accelerate to a different stage, et cetera? So that's really a patient preference thing. That's how we generally handle the treatment of atrial fibrillation. Luckily atrial fibrillation is not immediately life-threatening, so we don't say, oh, you have to do this immediately, et cetera. It's much more, let's consider it. You'll want to consider all your options and that kind of thing. But to his question about catheter ablation, and so we also individualize the approach with catheter ablation, meaning catheter ablation doesn't have the same outcomes. It doesn't even have the same risks often with certain patients versus others. So we have to individualize that overall. Luckily, overall, the success of catheter ablation has gotten better, over the last 5 years, et cetera. So, but nevertheless, there are patients that indeed the likelihood of their needing another procedure, a repeat procedure, is reasonably high. And that's for certain reasons. So particularly patients who have been in atrial fibrillation for long periods of time. What's long? Several years. For example, continuously, would have a lower success rate than someone who just goes back and forth and has a few episodes here or there, as you might guess. And so that's that spectrum when we'll talk to the patient. Now, that doesn't mean the decision will be any different for the patient. The patient might say, yeah, even though you told me and my success may not be as high as for somebody, for me, I really want to do this because that's important. It's important for me to try to do that because I think I might benefit from it. And that's what they'll choose to do. So it's in that perspective, et cetera, in terms of that. But there are certain patient-related, kind of characteristics or individual situation that may make the success more, higher or lower. So that's kind of what we would say.
It's a great time to have what we call shared decision-making between your doctors and the patients. One other question, cardioversion. You didn't mention cardioversion, which is shocking the heart. And there's frequently among my patients and among primary care doctors, it's confusing about who gets shocked and who doesn't. How do you decide?
Yeah. Great. Good question. So the patient who has atrial fibrillation that goes back and forth, we know that's kind of the nature of their atrial fibrillation. So we don't have to purposely shock the patient. We'll use medicines to try to keep them in normal rhythm when they go in normal rhythm. On the other hand, there are people who kind of get stuck in atrial fibrillation. We could wait, and it's generally not going to convert on its own. And so when we recognize that, we say, okay, well, we're going to need to help it along. And so the help it along typically is an electrical shock. So it's a very, we have anesthesiologists, you're put to sleep for a couple minutes, and you get a shock, and it generally is successful in converting the patient back to normal rhythm. To keep them in normal rhythm, however, many of our patients, not all, but many of our patients will have on one of those 6 medications, the antiarrhythmic agents, to keep them in normal rhythm so they don't just go right back into atrial fibrillation. So the conversion usually requires the shock. Sometimes, I'd say not too frequently, the medicine will convert them, but generally you need the shock. And that's the reason, right? So they're kind of stuck in atrial fibrillation. You say, gee, I want to come out of atrial fibrillation. How could I do that, doctor? And so we say, yep, this is a pretty good option for you. Pretty low risk overall to be able to get a conversion, get you back in normal rhythm, and see if we can keep you in normal rhythm. So, yeah, great, good. So let's go to the kind of the thing that we think about a lot, and that is on the basis of patients that have atrial fibrillation are, as a group, more likely to have a stroke or be at risk of having a stroke than patients without atrial fibrillation with the same characteristics. And so we think that's one of the biggest goals. Sometimes that gets a little not in the center, right? Some people will, patients and stroke prevention is really important as a result. But sometimes we're so, thinking a lot about symptoms that we kind of maybe don't remember, one of the most important things is stroke reduction. So let's talk about that. So this is the very early experience, which has really held up for decades. And that is, one can reduce the risk of stroke very, very substantially, like tremendously, by taking medications. And they're called anticoagulant medications. This slide was from the very original series where we only had warfarin, Coumadin, warfarin, et cetera. But the difference between the nose medication situation, the yellow bars, compared to the blue ones, aqua, is big. And so you can see you can reduce the risk very greatly. So what do we do now? So the practice now is based on trying to roughly estimate for an individual patient what is their approximate risk. And so we use a scoring system that takes consideration of the patient's characteristics. Do you have diabetes, high blood pressure, congestive heart failure? What's your age? Have you had a prior stroke? Things like that. In addition, female, male, vascular disease, etc. And you add up these little points that you get, and then you determine a score. For patients, and we can come back to this certainly, for patients, men who have a score of 2, women have a score of 3, they're recommended uniformly throughout the world to be on an anticoagulant. Patients that have a score of 0, in fact, do not get anticoagulated generally. Selectively they might in certain circumstances, but not all patients. And then the intermediate ones are kind of in the middle. They may or may not get treated with anticoagulant. We can talk more about that. And now, luckily, we have many more agents. And so these are the new oral anticoagulants. They have great, some characteristics that are, I think, much more convenient for patients. They don't require the regular blood testing that you need for warfarin therapy. They don't have the same drug or food interactions. Oh, you can't eat this and that, and those kind of things. So really, as you know, I think we'd love to hear what Dr. Lin says. These are the most common when we initiate someone for the first time on anticoagulant. We're more likely now to use one of these agents. Great.
Yeah, I think this has been night and day really since these new drugs came out. I think the biggest challenge that I have encountered is insurance coverage. So that's, really, if it's very expensive, I think that has changed a lot. I really, the electrophysiology clinics have been of great help because they were able to get, coupons and so forth. But, still it does happen where we get patients who say, geez, I would love to switch from warfarin, or instead of taking warfarin, to take one of the newer agents, and it's expensive and I can't afford it. So, that's an area we need to work on. Still get a lot of questions about bleeding. So that's a big issue in the conversation, fall risk, and taking things like, oh, if I'm on a blood thinner, can I still take ibuprofen? So what do you tell your patients when they ask you those things?
Yeah, no, that's good. So I think, again, it's for every individual. So unfortunately, I mean, the situation for some patients, they can't be on an anticoagulant. There's some what we call absolute contraindications, things that they just cannot take. So what will be an example? So certain people who have, something called an AV malformation in the brain, they probably couldn't do that. Certain people have bleeding disorders, inherited bleeding disorders. They probably can't be on anticoagulant. So relatively few have absolute contraindications, but there are many people who have kind of relative consideration. Well, I had an ulcer. Should I, what evaluation do I need? So that usually prompts an evaluation by the primary care physician, sometimes their gastrointestinal specialist, to weigh in. Oh no, you're safe. That's all cured. You can actually take this. So that's part of the discussion. And then issues of stability, falling, et cetera. Are you more prone to fall? Do you fall frequently? That's got to be weighed in terms of the risk of bleeding, et cetera. So those are some of the considerations. Yeah. What else would you say about
a lot of questions I get are, if I'm on these blood thinners, what if I start to have a nosebleed, which is not uncommon.
Yeah, exactly.
Some people will stop. Some people also, these drugs come in varying doses. So it's sometimes easy to say, geez, I'm going to take half dose, or most of these drugs, except for rivaroxaban, are twice a day. So it's important to discuss with your doctor. Again, as Dr. Wang said, you have to really individualize. In most cases, nosebleeds are self-limited and they will stop. Sometimes they can be very persistent. Sometimes you can lose a lot of blood. So really, that's a great time to reach out to your doctor and find out for you individually what your risks are, why you may be having bleeding, other symptoms where we may be worried that you bled too much. So it's an area where it's very complex, and you don't want to navigate that by yourself by kind of changing things without some expert advice. And then I also frequently get a question, well, which one out of the new agents, and that's a hard one for me to answer. I tend, doctors, we tend to have habits of prescribing the same drug. So, apixaban is very popular now. I think that's probably one of the more commonly ones. Dabigatran came out first, then rivaroxaban. And rivaroxaban is also frequently prescribed because it's once a day. So some people worry about adherence. So any thought? What do you say when people ask you about which one?
Yeah, it's great. We do have some considerations, but they're not very frequent. Like, so if you have kidney dysfunction, more people will be on apixaban or Eliquis, for example. We ask patients, if you really want once a day, then it really is rivaroxaban or Xarelto. It's the only one once a day. Probably the only real difference in side effects is probably dabigatran or Pradaxa, a little more likely to have gastrointestinal kind of upset, et cetera. So patients that have that on Pradaxa will usually switch them to another agent, for example. There's some evidence in terms of comparing them, what one being better in terms of bleeding, et cetera. There's some literature on that, so there's some consideration of those for some people as well. So,
great.
Yeah.
Thanks.
Good. Great. So we're kind of to our last topic, and what can I do? How can I prevent atrial fibrillation? Are there things? Now, as we started, very often there are things you can't do. We've not invented a way to turn back the clock. We've not successful, in terms of that. So as we age, probably the most important factor, or a very important one. So we can't affect that. But we've kind of talked about many of these things that are possibly intervenable. We can treat our blood pressure better, our diabetes or metabolic syndrome that might involve weight loss or a dietary program, hyperlipidemia, obesity, sleep apnea. Stress, as we talked about, might be something you can intervene with changes in lifestyle, behavioral therapy, and other kind of things, activities, smoking, alcohol. So there are a number of things that we think for some proportion of patients, but as you know, not all. Many patients say, well, I don't have any of those things, what can I do? And so this is part of the whole picture that we talk in terms of our patients. And there have been a number of kind of comprehensive programs that talk about really all the things that we talked about on that last slide. And by doing those intensively, that's kind of called a risk factor management program, that we kind of pull it all together. There are some data actually that kind of support this, meaning if you engage in these programs or certain elements of them, maybe you could do better. So the red line are people who have lost 10% of their body weight overall, which is actually quite substantial. It's hard to lose 10% of your body weight. But the curve, the higher the better. They do vastly better in this series than people who didn't lose that kind of weight. So for some people that makes a big difference, others maybe not so much. But it gives you some hope that there are certain things that you can do without medications that can help. And so regardless of what your therapy is, even if you take medicines or ablation, that actually does help. Some people think, oh, I could just get an ablation and it won't matter whether I lose weight or not. Well, it does actually. Your results are going to be better by and large. We have a number of different programs that we run, and I'll show you one of the studies that one of our members of our team is doing. We're actually embarking on a new study, just approved, to look at bariatric surgery versus no bariatric surgery. Both groups of patients get atrial fibrillation ablation, catheter ablation we've talked about, but only half get bariatric surgery for people who have significant obesity. Oh, I'm sorry. Bariatric surgery refers to a weight loss procedure that our general surgery colleagues do. This is from one of the studies that my colleague Linda Ottoboni is doing. It addresses questions about mindfulness, AFib education, etc. This is part of a kind of a package program that basically she's involved in studying to see what the impact is on atrial fibrillation. So what are our take-home messages? We kind of talked about initially. Just calming the rate down can be really important. Some patients really benefit from getting back to normal rhythm with medications, etc., catheter ablation. We've talked about the really important topic of stroke reduction with anticoagulation. And then finally, addressing these many factors that may contribute, obesity, hypertension, diabetes, sleep apnea, stress, etc. So great, I'm going to ask Dr. Lin to add to that in terms of his perspective of what can we do.
I just wanted to emphasize, everything, the list you showed earlier with prevention tips, this is to me just wellness and healthy living, right? Those are all good health habits, and so we should all try to kind of strive for that, whether or not you're worried about AFib or cardiovascular disease or diabetes. Other things I wanted to also, just kind of a side note, we are, Dr. Wang and Dr. Stafford, Randy Stafford, are leading a American Heart Association study to improve shared decision-making with a new digital tool. So this series is part of that grant as well. So, well, thank you so much for your time. I appreciate it.
Thank you. Thank you.